you're all here. Let me say that right now we have the Federal Medical Biological Agency connected. Doctors can ask questions from the agency. Thank you those who are online right now. And I would like to ask the first question to Angela Furtseva. Angela, I remember you had a very interesting study in Novosibirsk on 1,000 patients. Well, you studied the comorbid conditions of glaucoma and AMD. And as far as I remember, in 20%, there was a combination of these two diseases, glaucoma and AMD, usually dry AMD, as far as I remember. And well, in your view, Angela, are there any peculiarities in managing patients with glaucoma if they also suffer from age-related macular degeneration? Thank you, Natalia, for this question. Of course, well, dry AMD, well, usually it's dry age-related molecular degeneration in patients with glaucoma, and many speakers today mentioned about the neurodegenerative character of the disease. Pathogenetic mechanisms are similar in both cases, and that is why the therapy here is aimed at the general pathogenesis. If we're talking about dry age-related macular degeneration, and the neuroprotectors should be administered here to treat neuropathy. In speaking about patients with liquid AMD. There are not so many patients, but we do have them. They get the angiogenesis inhibitors, and here the major factor is the risk of progression due to the fact that there might be an increase in the intraocular pressure. It does occur during the injection, but after some time it goes down. If this elevated pressure is just a short time, so we should just measure the pressure IOP before the introduction of the angiogenesis inhibitors and after, especially patients with glaucoma. If the patient is on DMARDs, a basic therapy of glaucoma, if the patient is compensated, if IOP is normal, in this case, we did not see any, well, how would I say it, any elevated IOP as compared to patients in the control group, because 40 minutes after the injection, after an hour from injection, everything came back to normal. But when we looked at patients with diabetes mellitus and glaucoma, this is a separate group of patients, and a group of patients who were on angiogenesis inhibitors. In the long-term period, of course, well, glaucoma progressed faster in this group of patients. That is why your presentations were important, because they showed the necessity to correct the metabolic violations, well, to correct the pathogenic mechanisms. And of course, that's very important, and I think that's our future. Thank you very much. Dr. Chan, can you hear us? I would like to thank you, first of all, for your wonderful presentation. It was brilliant indeed. A lot of information, a lot of unusual information, I would say. But one way or another, the leitmotif of your presentation is the use of mitochondria, and you offer the universal mechanism of impacting on mitochondria, on other cells, and well, you know the targets of your impact well, but you solve specific tasks. So will it happen like this? A universal impact can lead to other negative consequences when you cannot assess such negative consequences. The system is universal, and there might be, using this particular system, a negative effect on other organs as well. What do you think about it? Thanks for the question.
Yes, I think the multiomics is important and used for the glaucoma research and finding for the deeply mechanism and find the early biomarker for prediction prevention. and the prognostic assessment.
If possible,
Спасибо.
I can interfere if
Спасибо.
you
На самом деле,
allow.
это ожидаемый был ответ с одной стороны, а с другой стороны...
Hello?
If you allow, I would like to interfere here because I think that there is a lot.
Пожалуйста, пожалуйста.
Yeah, thank you very much.
Yes,
So, first
please,
of all,
you can add.
Thank you very much to all speakers. Excellent
So my
presentation.
screen is blocked here. Okay, thanks.
Thank you very much again, Professor Zhang, for your presentation. Just wanted
So when I was the proteomics, I think the proteomics is useful for the deep, also including the tiers, the automics. Well, it's not.
Professor Zhang, if you agree, I would continue because I
So
think
my
that
computer have some problem now. Sorry.
Professor Kudisheva,
Мы
may
вас
I
хорошо
continue?
слышим и видим. Пожалуйста, продолжите.
We can see you, we can hear you. Well, Olga, you may continue.
Okay. No.
Пожалуйста, не слышит нас, к сожалению, Ольга Голубницкая. Я хотела как раз
Olga, can you continue? Olga, I would like to ask you about the prospects of personalized medicine because, well, there is a lot of experience in this field. Olga, as you know, is head of the very famous journal where they have first-hand publications in different fields of medicine related to preventive, predictive, and personalized tactic of treatment. That's the medicine of the future. And maybe Dr. Jean could answer this question as well, because just like me, Dr. Jean represents his own country in this international community. Dr. Jean, what's the role of personalized medicine? I have a question, if I may. Well, in your view, the results of proteomics, metabolomic studies, genetic studies, will they allow us to give a breakthrough in diagnostics first or in treatment?
So probably I can continue.
Да, Ольга, вы нас слышите? У меня вопрос к вам.
Yeah, very well.
Olga, if you hear us, we have a question. Did you hear the question?
Just first of all, in the context was what was presented by Professor Zhang. I think that somebody can be confused why so much attention was dedicated to cancer. And to this point, I would like to stress that there is a big overlap between multifactorial disorders. On one hand, eye disorders, as we heard today from excellent topics and presentations. On the other hand, in the area of cancer, probably cancer research is more advanced. That's why we can learn a lot from multifactorial disorders, predictive diagnostic treatment in cancer, and then to adapt it to other areas. So, but today we heard, for example, that metformin is a very promising neuroprotective drug for glaucoma on the one hand. On the other hand, it is excellent anti-cancer drug. So this is a really big overlap between both areas. The same also for anti-VEGF. Angiogenesis. So the same for eye disorders, but also for cancer. So there is really a lot of overlap, and particularly at the stage of primary care. That's why my message, again, what I mentioned already at the beginning, that we should focus not only on the treatment of manifested disorders, but also on population screening at the level of reversible damage. Why? Because there is a lot of, as Professor Kurisheva said right now, there is a lot of accumulated knowledge regarding phenotyping and patient stratification. Probably you remember Flammer syndrome phenotype carriers. If somebody doesn't know the name, the definition is sympathetic overdrive. It means disbalance between sympathetic and parasympathetic activation. So which leads to, for example, extremely high level of reactive oxygen species, toxicity. It leads to glucose metabolism shift. It leads to extremely high level of stress sensitivity, to low-grade inflammation, to small vessel disease. All these components we observe in eye disorders like multifactorial glaucoma, but also in cancers. And the idea is to look for, coming back to your question, Professor Kurisheva, what will be first and how to probably consider it in parallel. Predictive diagnostic is extremely important for cancer screening, for glaucoma predisposition screening in population. And in terms of this, we need natural biosensors. There are a lot of projects, for example, at the European level, submitted now how to elaborate on biosensors instead of to make annual checkup, because within 12 months there is a lot of happens, and that's why what we need is really biosensoric, day by day. And for this concept, we have elaborated on the mitochondrial checkup. For example, in tear fluid, not only metabolites, but also mitochondrial homeostasis. This is extremely powerful instrument, particularly for primary care, but also for therapy monitoring, how effective it is. Because can you imagine that anti-VEGF, we have statistics, but the results differ from case to case. The same also for metformin. Results differ from case to case. That's why we need to work with individualized patient profile and biosensor monitoring, utilizing, for example, mitochondria. And for that, it is not only at the level of scientific excellence, but it is also at the level of providing services to the patients. This is very, very important. And I would like to refer to the new enterprise in Austria, Medicon, which is already utilizing mitochondrial homeostasis measured in tear fluid to observe the health status of the patients prior the therapy, during therapy, after therapy, but also in primary care. And these services are already provided to patients in Austria, Germany, Belgium, Spain, but also we start to work now with experts from Russia who are involved in mitochondrial health. And probably my suggestion to make a follow-up brainstorming together to invite mitochondrial experts from Russia and ophthalmologists, how to organize the patient stream for population screening, but also for treatment monitoring. Thank you very much.
интересная и очень сложная тема, но это абсолютно
Yes, thank you. That's a very difficult topic, but that's a new paradigm in medicine that will definitely will be used in treatment of ophthalmologic diseases, glaucoma. We have doctors from the Federal Medical Agency. Maybe you would like to ask a question if there is any. Can you hear us? Yes, sir, we can hear you okay. Hello, colleagues.
Good afternoon, dear colleagues. Very interesting presentation. I have a question to Igor. So you showed very comprehensive advantages of aflibercept as Elia, 8 milligrams, but we have a question on whether it's really truly the best anti-VEGF which can be used in practice, or maybe it has some limitations, still have some limitations in the using of Elia. Maybe it is not the best in all the situations. Maybe there are some limitations or exceptions. Please speak up. Well, thank you very much for your question. Well, this question seems a little bit strange to me because anti-VEGF has very clear indications. And the indications I showed in my presentations, this is an AMD and DME. So that means the indications are very, very clear. But here it means that the drug itself is very well known. We know safety profile, we know efficacy, but the question here is that the option that is already very well known, that has great reputation, but now we have option which could play longer, that definitely adds on some attractiveness. So it's becoming more attractive. What do you mean by the changes of indications? Indications are the same, so it is not clear to me. So what I mean are disadvantages of using it because in fact we know the number of other treatments which can be used with the same indications. Well, in fact, to put a shadow on the whole line of anti-VEGF, we don't have this task, so we cannot say that something is inferior or worse safety profile. No, we don't have this task, so we don't want to cast any shadows. In fact, we are speaking about the drug, which is changing the properties with increased dose, but here we are not risking any safety, but in fact, it leads to the high efficacy. So that's the point. And the other drugs, definitely, we are welcoming all the flowers in the field, so no problems here. So you do head-to-head comparison, you have your own data, and will speak scientifically. But the question here is that every drug has its own, let's say, profile. Aflibercept in the existing option has its own specificities, so anti-VEGF plus additional activities. So I'm not going to, let's say, clarify all that, but I think it's more attractive because it's safe, it's efficacious, and now it's getting more. When there is something new coming here and we have no yet a lot of experience, it's always a question whether it's effective, safe, whether we have to trust it or not. But now the drug, which is very well known, and now it's additional attractiveness. So now it's a longer interval. So this is Elia 8 milligram, aflibercept of 8 milligram with longer intervals of injections. I hope I could answer your question. And actually, I liked the presentation of Dr. Larin. So we formally understand that you can say, yes, it's diabetic macular edema, and you introduce anti-VEGF due to diabetic macular edema, DME. But you see, the topic of traction is actually much more important here. And you describe these changes yourself. So we see that it leads to serious changes in the retina. But the topic to use preventively, yes, maybe you meant something like that, but this is not directly along the indications, but this is very useful story. Yes, anti-VEGF preventively, why not? But this is the way how we can make it easier, the intervention and also improvement of functional and anatomical results. So yes, this is very interesting story. I have another question to ask. Yes, rough changes of the vitreous body that is playing like a depot of the drug. But then we have many questions. How long should we wait after the injection? What is the injection point? Yes, because it is non-homogeneously changed, and you can get with injection where there is too much fibrosis, maybe, and maybe even a technical question. So, in fact, it's just the extension of indications here. So, especially in the topic of comorbidity. So probably this is the option of vitreal surgery. And I truly believe you're right. I'm sorry, but probably you can give some explanations here. Thank you very much for the question about the technical component. So it could be any location, like in the standard intravitreal injections. About the vitreous body changes, definitely this is diabetic retinopathy and we can do nothing with that, but it's an interesting question in terms of whether we need to introduce anti-VEGF in some cases, because as far as we know, so it could stimulate and increase the traction. So in macula, in fixed retina, so there is increase of traction with the introduction of the product. So maybe we can increase the traction and somehow the piece of retina could be changed in a particular position. Unfortunately, sometimes it happens in fovea. And then if we see, according to the optical coherent tomography, if we see picture like this, which is predictive for negative complications, definitely these patients are not candidates for anti-VEGF. So indications and the preparation for vitreoretinal surgery. So I think so it's yes, it's conservative treatment of retinopathy.
Именно что это в рамках подготовки было бы здорово, но пока имеем то, что имеем. Есть показания пролиферативная диабетическая ретинопатия.
So there is indication proliferative diabetic retinopathy. So this is the only treatment ranibizumab. So it's along the indications.
Замечательно, спасибо большое. В принципе, я хотел просто акцентировать на этом внимание, то, что вы сейчас все очень подробно изложили. Мне
So thank you very much for very comprehensive explanation, and I think it could be just for the benefits to all of us. So these are not just some words. So our task is to draw attention to most important moments of our general content. So we want the doctors to know and understand that in fact it's all done for them, and we are just clarifying some important focuses that could cause additional questions. So that's my position, and we wait for some more questions to ask to colleagues, to each of us. Well, colleagues, unfortunately we are very much limited in time, so we're a little bit behind the schedule, and I'm extremely grateful to all the speakers, to Professor Fursova, Professor Loskotov, Professor Jan, Professor Larina. If you want, you can stay longer,